Good morning. Thank you, Doreen, and thank you, Stella, for that nice introduction. And welcome to everybody joining us today. As Stella said, I am a family physician in Vancouver. I do have a consulting arrangement with Midmark, which is a company that makes exam room tables, so don't ask. And I don't think being the co-chair of the BP measurement and diagnosis subgroup is a conflict. So I have no financial support for this talk, and no in-kind support, and no conflicts of interest. Here are my objectives. We're going to talk today a little bit about blood pressure measurement, talking mainly about both office and out-of-office measurement, and trying to understand some of the background to the recommendations that we made at the Hypertension Canada. But before I do that, can I just, do you mind if I poll the room a little bit? I just want to know, if you don't mind, by just a show of hands, how many of you are nurses and family physicians and pharmacists? There's a few ringers in the room, department heads, hospital heads. Thank you. I appreciate it. We're going to talk about measurement, and then I might ask you afterwards how you measure blood pressure measurement, and I appreciate if you just be honest, and let's talk about it objectively. So Hypertension Canada, a couple of years ago, we changed our algorithm for diagnosis, and I think most of you have seen this. Hopefully you've seen this before. It's divided really into three sections. I don't know. Do we have a laser pointer? Do we have a pointer? Do we have a mouse? No. Okay. Well, it's divided into three sections. At the top, elevated blood pressure readings through screening, either at in the office, home, or even in the pharmacy. And then, thank you very much. And then a dedicated office visit to assess, the level of blood pressure, and then we've moved into a recommendation for out-of-office blood pressure measurement to confirm the diagnosis. So let's just take you through these various areas. Oops, did I do that? What did I do? How did that? What did I do? Oh, there I go. Okay, all right. Office blood pressure measurement, we've divided into two types of office blood pressure measurement. One is an automated office blood pressure measurement where the patient's left alone in the room and a series of readings are done automatically. The other type is attended by the healthcare practitioner, and we're going to talk a little bit about how that might be done. Out-of-office measurement, you're all familiar, I'm sure, with home blood pressure measurement and 24-hour ambulatory blood pressure measurement. We'll talk about all of those types. In 2015, 2 years ago, SHEP at the time, the predecessor to Hypertension Canada guidelines, came up with this recommendation, strong recommendation. It's really quite unique in that we recommend strongly that blood pressure measurement in the office should be done using an electronic device in the upper arm, and we feel this is preferred over the previously performed auscultatory methods. This is a strong recommendation. It was a long time in coming. There's a large body of evidence that shows that really in the real world, routine office blood pressure measurement is not the same as the standardized research quality office measurement that was used to achieve some of the targets and thresholds and goals that we learned in the early years of hypertension study. That type of research quality is done in some clinical trials, but really in the real world, the world that we live in, it's a very different measurement. So there were a number of studies that looked at this, and Myers summarized just a few of them, and you can see that really routine office measurement is higher in general than standardized office measurement. Sorry, standardized research quality measurement. The next year, last year, 2016, we came out with a recommendation that automated blood pressure measurement, AOBP, as it's now commonly called, is the preferred method of performing in-office blood pressure measurement. And I'm going to take you through some of the background for this recommendation. Automated blood pressure, office blood pressure measurement is done using an electronic device, again on the upper arm. It automatically performs multiple readings, calculates the mean, and really the key ingredient in this is that the provider, the healthcare provider, leaves the patient alone in the room. And actually, I've changed this slide from the one that typically is used by Hypertension Canada. I think it's not enough just for the provider to be out of the room, but you got to get their family out of the room too. So this is really an effort to mitigate the white coat effect. There's a growing body of evidence that AOBP is predictive of the target organ damage that we're hoping to avoid in patients with hypertension. Andriadis from Greece published a couple of papers, one showing the correlation with left ventricular mass index and another with microalbuminuria having predictive ability comparable to ambulatory blood pressure. And that built upon an earlier study by our very own Norm Campbell, sitting over here, who showed an association with carotid intima medial thickness as compared to office blood pressure measurement back in 2007. There is now some outcome predictive data from the well-known CHAP study, Canadian study again, that took over 3,600 community dwelling residents over the age of 65, untreated for hypertension, using a BP-True AOBP device in community pharmacies. They followed these patients for a mean of almost 5 years, looking at fatal and non-fatal cardiovascular events. And their results showed a significant increase in the hazard ratio at the blood pressure of 135 to 144 and a systolic, sorry, and a diastolic blood pressure 80 to 89. So consistent with the threshold that we've established at 135 over 85 for diagnosing hypertension. And I'm sorry those graphs are really small. I just wanted to put them in so I could show you what the authors concluded. If you don't have a device that does automated, unattended blood pressure measurement, we've made recommendations on how to get the best possible result. We call this office non-automated or non-AOBP, or you could call it standardized office blood pressure measurement. But again, trying the same principle of using an electronic device on the upper arm, single or multiple readings, but in this case, obviously initiated manually. Also in this case, the provider being inside the room, so it would be subject to white coat effect, hopefully positioning the patient in the same way, but remaining in the room. And again, we do strongly recommend that auscultatory methods not be used. The key to an accurate non-AOBP is using the standardized measurement technique, and we recommend in our guidelines that the first reading should be discarded if you're going to do multiple measurements, and averaging the last two. So we've established thresholds for both AOBP and non-AOBP. You can see they're slightly different. The mean, a mean of greater than 135, greater than or equal to 135 or 85 for AOBP, and 140 over 90 for non-AOBP. And it, we do apologize. It does lead to confusion in the recommendations, but this is the reality. And I'll show you in a second what the real reality is in terms of how we collectively in primary care measure blood pressure. So back to the diagnostic algorithm, I just want to talk a little bit now about out-of-office blood pressure measurement. Out-of-office blood pressure measurements came into the recommendations into our algorithm because it's clear that they correlate much better with risk than office blood pressure measurement alone. So you can see for surrogate markers like left ventricular hypertrophy and microalbuminuria that home blood pressure measurement and ambulatory blood pressure measurement are much more predictive. And this is because when you add the element of out-of-office blood pressure measurement, and I've adapted this slide, I guess this part, from as you can see, adapted from Shep, which is adapted from Pickering. And Pickering really introduced this model back in the early 2000s, where you can really start to separate out those patients with true normotension, so that means normal blood pressure in the office and out of office, and those with true hypertension, so high in both settings, from two other categories that really address the risk, and and it's really that area that we're trying to refine. So white coat hypertension is when the blood pressure measurements are high in the office but normal outside of the office, and we've been able to address that in our algorithm. The most difficult area is finding these patients with with the masked hypertension, because for all intents and purposes they're pretty hard to find unless you're doing screening with both office and out of office on people that have normal blood pressures in their office. It's important because the prognosis of white coat hypertension is very similar to the prognosis of patients with who are normotensive, and conversely, patients who have masked hypertension are the challenge, because their risk is the same or maybe even slightly higher than patients with uncontrolled true hypertension. So the definition of white coat hypertension, again, is that a patient is a patient with elevated office blood pressure, normal out-of-office blood pressure, and has a very high prevalence. Published prevalence is somewhere between 9 and 30%, but in a typical practice, I think you're talking probably closer to 20 or 25%, which is a very large number. And we really do want to identify these patients because their risk is lower. They don't necessarily need to be treated. In fact, we don't want to treat them. That just adds to, as Doreen was mentioning, adverse outcomes and adverse medication effects and a lot of other issues, including labeling them with a disease that they don't have. So to summarize, just out-of-office blood pressure measurement identifies both the white coat and masked hypertension. Ambulatory blood pressure measurement is more predictive than office blood pressure measurement, and we've recommended it strongly as the preferred out-of-office measurement method. And home blood pressure measurement also has better predictive ability than office. We've recommended home blood pressure measurement as a substitute to ambulatory if it's not tolerated, not readily available, or if patients just won't do it. Has anyone done an ambulatory blood pressure measurement? Would you like to do it again? Most of us wouldn't. Yeah, so that's out of office. So a group of us were interested in what was going on in Canada, and we did a pretty quick survey through the auspices of the College of Family Physicians, who have the ability to do email surveys. And so we did an email survey of family physicians, not a high number, about a little under 800 who finally completed it. But we asked a few questions, and in terms of how is blood pressure measurement done in family practice offices in Canada. A couple of interesting things. Gratifyingly, really just after a few years into our recommendation that AOBP is preferred, we have close to, well, more than a third of family doctors use AOBP in their practices. And just as gratifying, the same number, about a third, are using ABPM and or home to diagnosis hypertension in patients who have high office readings. But on the negative side, what we are seeing is still a large number of us are continuing to use manual blood pressure measurement, more than 50%. And even more frustrating is something that's not on this slide. We asked a question whether ABPM was available to their patients, and 75% of the respondents said yes, but really only 14% are using it. So obviously that's a barrier for our recommendation to be used. Obviously, we need to address that in the future. Not sure if everybody has seen what an ambulatory blood pressure device looks like. It's a cuff on the upper arm, some tubing that generally goes under the clothing, and a little recorder that you wear 24 hours. It's usually set to go to take a reading every 20 minutes during the day and every 30 minutes at night. And what we sorry, I don't know how well this comes out, but what we look for is we look first really to see that most of the readings, in this case over 93%, were successful. Then we look at the three averages, the daytime, nighttime, and 24-hour average. And finally, we look at the dipping component. And some of you have heard about that. I won't get into that detail, but dippers are lower risk than non-dippers. That means blood pressure lowering at night. And then finally, we have made recommendations in our guidelines about how to take home blood pressure measurement. Most of us are used to these little bits of paper that show up with scrawl, and you can't quite read them. And some patients will take their blood pressure every 13 seconds, and others will take them haphazardly. They toss some out, they keep some, they show you what they want, and it's really sort of difficult to utilize clinically. So we've made strong recommendations on how to do this properly. And there will be some further information, hopefully over the next couple of years, as we at SHEP look at recommendations for how to follow up patients. So that's coming. But what we really recommend is that you standardize, that patients standardize their home blood pressure measurements to take 2 or 3 readings in the morning with about a minute interval, and evening for 7 days, discarding the first day, averaging the 6 days, and really what you want is you only want to get one number. That's all I ever want. I want the average. I can't tell you what percentage actually give me the average. They usually make me calculate the average, but at least I'm trying. And Hypertension Canada does have some log books that that are available for your patients, and my clinics just organized a little bit of an Excel sheet that we send patients, and hope that they would send it back to us in Excel, so at least we can just push a button. And finally, we have at Hypertension Canada recommended that it's really important to teach your patients how to do this carefully. A measurement is only as good as how well it's performed. This is available at our website, and also we have this program that I think some of you have probably taken advantage of, that recommended devices. That means devices that have been independently validated, and we vetted their evidence and put it on our listed them on our website. We've revamped this program. We've got a new set of logos for endorsed device or approved devices, and you'll see more information on our website over the next couple of months. And that's really all I have to say. Thank you very much.